Coming up on the Doctor's Hospital podcast.
In the emergency room, we are starting to have more emergency room specialists. We're better able to make fast decisions and more accurate and more precise decisions.
Experience the immediate care you deserve at Doctor's Hospital Urgent Care. When emergency strikes, trust our expert physicians for fast, quality care. With extended hours and cutting-edge medical technology, we're always ready to serve you. Don't wait or take risks with your health. Visit our urgent care suite at Doctor's Hospital West on Blake Road for immediate, trusted, and best care.
Welcome to the Doctor's Hospital podcast. I'm your host, Alexis Burrows, Marketing Director at Doctor's Hospital. And we are pleased to be joined today by Dr. William Seymour, who is an emergency medicine physician here at Doctor's Hospital, one of our physicians out at Doctor's Hospital West, our urgent care center, and well-versed in the field of emergency medicine, here to talk about all things related to that field as we look back at the celebrations of ETS week back in May. We finally got a chance to sit down with him and talk through what that looks like. So I'd like to start this conversation with, how did you decide to get into emergency medicine in particular?
Thanks for having me, Alexis. First off, how did I decide to get into emergency medicine? Emergency medicine chose me. I am fortunate to be homegrown, like my seniors like to say. So when I finished high school, I started as a step student in Doctor's Hospital. I went off, did medical school, came back, and I worked as the physician assistant. And all of that was exposure, time within the emergency room. When I started my training, and I started as an emergency medicine specialty, it was mainly because my love of emergency medicine was found during that time. And I was a step student too, when I was a physician assistant at Doctor's Hospital. And so it grew on me, and it didn't want to let me go. It didn't want me it didn't want me to do any other specialty. So I'd say emergency medicine chose me. And I have never had a day of regret yet.
How different is it, do you think, from the other specialties? I imagine where in a lot of other specialties, you have a patient that comes in, it's kind of a little bit more slow paced, not necessarily always the go. But what is that difference do you feel like?
That big difference for me would be we make split second decisions. And so as opposed to being precise, we just have to be fairly accurate. Instead of knowing exactly what something is, we just have to know which direction we're going in. For example, if somebody comes to the emergency room and they say, I don't feel well, I feel nauseous as if I wanted to vomit, I don't have to exactly know why you want to vomit. I just have to know whether you're sick enough to stay in hospital, or is it that you should be discharged. And once we figure that out, we can kind of push you in that right direction and get the ball rolling, as opposed to another specialty where you're trying to figure out exactly what it is that's the cause of that nausea or that vomit.
Right, because I guess, generally speaking, you would have more chronic issues in a lot of the other specialties, where in the emergency room is more acute. It's in that moment, something that needs to be addressed right away.
Yeah.
Okay. Awesome. So what are some common misconceptions that people have about the emergency room that you encounter in your day-to-day experience?
I think the biggest misconception that persons have about the emergency room is that it is a magical place where you go, and once you give the doctors a vague description of what it is that you're feeling, they automatically know what it is that's wrong. That's wrong with you. We can figure out everything. We can take a tiny bit of your blood, pop it into a machine, and a big printout comes up and tells us everything. That's wrong with you. It kind of doesn't work like that. Emergency medicine is a place where, and I love this, if people would say, or my patients would always tell you, I'd love to say this, emergency medicine is not a great place to figure out what things are. It's a great place to figure out what things are not. So while we're there, I may not be able to tell you what it is that's wrong or what it is that you're coming for. What I'm trained to do is recognize when this is detrimental to your health, recognize when this needs to be treated right now, recognize which direction that you need to go in. I don't necessarily have to know exactly what it is. And lots of persons get that wrong, and they come in and they think that, well, because I He didn't tell me what's wrong. He didn't say exactly what's wrong with me. I didn't really get care or treatment. No, that's not exactly what the emergency room is for. We're here to make sure that you're okay, so we can continue to figure it out on an outpatient basis.
Mm-hmm. Any other misconceptions or myths that you want to talk to?
I think one of the other misconceptions about the emergency room is this was one when I was in training where people didn't believe emergency medicine was an actual specialty. They thought it was just a room where doctors congregated from all different specialties and they saw persons who may or may not have been having an emergency. No, it's an actual specialty. It takes a lot goes into preparing and going into that specialty. It's actually really intense. Other persons are, another misconception about the emergency room is they think that we're heartless. So I wouldn't say that we're heartless. We've just been very desensitized to lots of different things. So we do actually care if we see persons. If you ever have a family member that's an emergency medicine specialist, you would see something and you think you're dying and they just look at you like, oh, you're fine, you're going to be okay. It's not that they don't care. They just, they've been trained to actually figure out something life-threatening real quickly.
I found physicians in general have a very different view. I think desensitized is the right word. You see so much, right?
We see a lot.
Obviously in emergency room and even in other specialties, you see a lot and you tend to, like you said, be desensitized to it.
Yeah.
I think the interesting thing about your first misconception in terms of it's more of a process of elimination.
Yes.
Sometimes it's more critical to know what's not wrong.
Yes.
Because then it kind of still guides you on a path, even though you might not know acutely what is wrong in that moment.
Absolutely.
And again, moving to that idea of this person needs to be admitted. Do they just need to stay here for a few hours? Do you need to refer them to somebody else on the outside after the fact and that sort of process?
Absolutely.
Which kind of brings me to my next question. What does that typical flow of a patient journey look like from the minute they walk in the door to the emergency room, through the process of, is this admission, is this, observation, and then discharge?
Yep. That could be varied based on what it is that you present for. Some persons may arrive they may get to the department in an ambulance. And another thing is when persons arrive in an ambulance, they believe that means that you're automatically going to be seen first. No, not necessarily. We, in the emergency room, we have a system and we go through, after your arrival, we go through something called triage. And that's where we try to figure out or sort which level of urgency it is that you have. Is it that I need to see you right now? Is it that I need to take some time before I see you? And so when you arrive, we try to figure out how severe your issue is. Is there anything that we need to address immediately or that could kill you within the next few seconds to minutes? Once we've addressed that, then there's workup and there's treatment. We would do any number of imaging or blood tests, or we try to give you some pain medications, perhaps something for vomiting. And once we've gotten to that point where we have enough information to make a decision, we try to send you in that pathway. So if we figure out that, okay, this person needs to be admitted to the hospital for further care, we know which specialty it is that we're going to send you to. And then, or if we can say this person is well enough to go home, then we can go ahead and get you discharged. So that whole flow looks like you arrive, we sort you, we figure out which level you're at, we put you in a room, we do any number of tests, blood tests, imaging. They give you some treatment to help alleviate your symptoms. And then we make a decision as to whether you're coming, you're going, or what's going to happen
looks like,
next.
right?
Yeah.
Okay. I mean, I guess that helps to speak to, a common complaint when it comes to any emergency room, and sometimes even in the urgent care space is, why does it take so long to be seen? And I think maybe to some degree that answers that, right? Because it is the process of where are you in terms of level of life threatening,
Yes.
What additional testing you may need when you go, because you may go through a first round of tests and a second round of tests. And I think that helps to kind of assuage that a little bit. Anything else you want to add to just that complaint that people may have about the length of time it sometimes takes to navigate through the emergency room?
If you take longer, well, we try our best at the doctor's hospital emergency room to have you in and out in under 4 hours. Sometimes we can deviate off of this, but that would be in exceptional circumstances when
Mhm.
we're really doing a deep dive or trying to figure something out. Other than that long time, it's not intentional. We
Right.
really don't want to keep you there for a long time. We're trying our best to get you um, to or make some sort of disposition as to where it is you're going to go. Are we going to send you home or? But so it's not intentional. To everybody that's ever waited in the emergency room for a very long time, we humbly
Mhm.
apologize. It is not
Right.
intentional.
Okay. So, given that, what advice would you give to someone outside of the timing part of it? Would you give to someone who needs to visit the emergency room for the first time?
You um, it can be an intimidating place. You get in and you will feel it's easy for you to get lost in the
Mm.
emergency room or feel as if you're lost. You see persons zipping past real fast. Um, and I had one person say one time, it feels as if I'm just another person. It doesn't feel as if there's something individualized to me.
Mm-hmm.
And I said, I'm sorry for the way that you feel. Do know that it's not personal. Do know that we have actual emergencies going on. And sometimes us zipping past real fast is not that we're ignoring you. It's just that we've glanced real quickly and realized that you're probably okay. And we shot over to somebody that's not as okay as you are.
Mm-hmm.
So when you go to the emergency room for the first time, don't take that personal. You want to really set specific goals. And I know that seems um, cliche to
Mm-hmm.
you go to the emergency room and you think, oh, this is an emergency. I didn't plan an emergency. When you go for every visit, I like to tell persons be very concise about what it is that you came here for. What do you expect to get out of this visit? What do I
Mm-hmm.
mean? Um, at 3 in the morning, if you come to the emergency room and you said that you've had chest pain for the past 4 years, I am probably not going to be able to figure out what that is in the space of that 4 hours that we talked
Mm-hmm.
about. But what I can answer is what was it that made you afraid enough at 3 in the morning to
To
say,
come here.
why are you here?
Mm-hmm.
And if you can identify that goal with me and say, Doc, I really, really want to know why did the pain move to my left hand?
Mm-hmm.
And I want to make sure I'm not having a heart attack. Absolutely, I can do that. So if you set that specific goal, or have an idea of what it is that you want to get out of a visit before you come, you're already half the battle is already won.
Mm-hmm.
The other thing is be very concise in your information. Sometimes persons like to tell us, "Oh, I'm having pain, and then I cut my ear about 4 years ago, and then one time I chipped my fingernail, and the cut was a bit short." That's well and good, but
Mm-hmm.
that's once again in that snapshot, concise. What is it that's bothering you? The main thing. What is it that you expect to get out of it? What is it that your big concerns are?
Mm-hmm.
The other thing that person should worry that they should try to do when they come in is uh take a companion.
Mm-hmm.
Sometimes it's good to have a sounding board, or it can be intimidating, like we said
Mm-hmm.
earlier on. You want somebody to be able to be there with you, or voice opinions for you, or if you have concerns, you want to be able to share that conversation with somebody and get deep into it. So those are a few pointers
Mm-hmm. Okay.
persons can use when they come to the emergency room for the first time.
Okay. What advice would you give someone who may be sitting at home and trying to decide, okay, is what I'm dealing with right now something that requires me come to the emergency room? Should I just call my regular physician? What are some of the key points of, okay, if you're at this fork in the road or is this decision tree, this says, hey, you need to come to the emergency room versus going to your regular physician or even going to an urgent care center?
Um, if you have a regular physician and you're able to get in touch with them over the phone, that's good because that kind of helps us out a lot in the emergency room.
Mm-hmm.
Through a conversation with your regular physician, and you tell them your symptoms, they would be able to say, well, I think you're well enough to come see me in the morning. Or
Mm-hmm.
they would say, based on what you tell them, I think you need to go to the emergency room because I want to make sure that you're not having this problem or that problem.
Mm-hmm.
What then happens is they call the emergency room ahead of time and they say, so and
Expect so
so,
and so.
he's coming in and I'm concerned about
Mm-hmm.
this. And so they've already paraphrased and made your information so concise that I
Mhm.
know exactly what it is the main problem.
Right.
Of course, we look for other things, but they've already started your process.
Yeah, it kind of gives you a head start.
It gives you a good head start. The other thing is Dr. Google. Now, Dr. Google is not licensed to practice in the Commonwealth of the Bahamas. However, Dr. Google can provide some useful information sometimes. And you would want to look for what are the red flag signs and symptoms, or let's say you're feeling, I feel tingling in my fingers.
Mhm.
And you go to Google and you say, should I be concerned about tingling in my fingers? It's going to give you a lot of answers, but it'll give you a few things that you need to pay attention to. And that you can say, hey, listen, it'll say you probably should go to your emergency care center right away. The other thing that sometimes work, I can't tell you it'll work all the time, but you could give the emergency room a call. And you says, I am so and so. I have this symptom. I'm concerned about this. Do I need to come and see you?
Yeah, I think the point about your I guess your regular doctor,
Yeah.
whoever you go to and see the most, is a good point, because I imagine they'll also be able to fill you in on any important details in the patient's history that predates this particular call that they received, and then forwarding them on to the emergency room. Because I know we've seen in a number of the conversations we've had recently on the podcast how critical a patient history is.
Yes.
In terms of both sometimes, shortening that process of the wait time, even because if you know there are these specific things, you're actually going to run a litany of tests, but you have a pinpointed thing that you're already targeting.
Yeah.
And so, yeah, we've seen that concept of having a good patient history is very critical in the process.
Yeah.
I think you may have answered this a little bit already, but I guess if you can kind of add any details to it. But how do emergency physicians prioritize cases and decide who gets seen first in a busy emergency room?
We have a number of systems.
Mhm.
We have we sort you by urgency, and they have systems like the emergency severity index, where they take a number of physiological parameters, for example, your heart rate, your blood pressure, your respiratory rate, and they kind of say it gives you a score. And based on that score, we can see how urgent things are. That's one way. The other way would be the obvious. If you come in with your hand chopped off and bleeding blood all over the place, we probably should see you a bit quicker than the person who's having a cold.
Right.
There is also the pre-alert system that we get. For example, Doctors Hospital is now building a lot of pre-alerts. So if you call an ambulance and you get to them, and our ambulance team has been doing really, really, really well, when they get to you, they're going to start to plug and play as opposed to scoop and run. And what I mean is they'll get to you, take a bit more of a history, do a bit more work, and they're able to figure out what to tell the emergency room when you're on the way. So they'd say, I have somebody who has a possible stroke alert. So I said, okay, we know that we now need to clear out a few things and facilitate our processes so that we move lightning fast to give you or your loved one the best chance of survival. So it's based a whole lot on what you say. And then we also in the Doctor's Hospital emergency room have any number of physician assistants as well as nurses, and they're all well trained and seasoned, and they're able to see certain things. They're able to start certain processes. And let's say, for example, you come in and you say, I have chest pain. They said, no problem. You look fairly stable, but after they've done any one of the number of preliminary tests, it triggers a red flag, and it says, oh, this guy's having a heart attack. I know I need to prioritize you. And so there are a few things. I think I used to have these German colleagues I worked with, and they would always say this word. I learned two words. One was Fingerspitzengefühl. And I was like, what's that? He said, and as I Googled it, it meant that fingertip feel, that thing that you can't get out of the book. But after you've been doing it for a while and you see different things, it's that feel that you have. And the other word that I learned was Korkenzieher, and that was it meant corkscrew, because they had really nice wine when they would come in.
That's a perfect place for us to take a break. We're having a very, very good conversation with Dr. William Seymour, and we'll be right back on the Doctors Hospital podcast.
Are you uninsured and seeking a plan that can give you quality health care at discounted rates? Unlock affordable healthcare with Doctors Hospital's LAMP. Enjoy unlimited primary care visits, exclusive discounts of up to 20%, and complimentary imaging and nutrition services. Visit doctorshosp.com/LAMP to register. Comprehensive, cost-effective wellness starts with LAMP.
Welcome back to the Doctors Hospital podcast. We are still joined by Dr. William Seymour talking about all things emergency medicine. So we recently opened in New Providence an urgent care center at Doctors Hospital West. Similarly, we have an urgent care center in Grand Bahama in the city of Freeport.
Right.
And we're preparing to open another urgent care center in Paradise Island very soon.
Right.
And obviously, we talk about urgent care, we talk about emergency. What are some of the key differences between what an urgent care center offers and what the emergency room offers? And you can be specific to our environment or just generally.
All right. I think one of the key differences that we provide is the level of acuity that we treat. So, for example, a bit earlier we had talked about how do we prioritize different cases.
Right.
There's some cases. So, in an urgent care center, we're able to give you a certain level of care. We're able to fix your broken bone. We may be able to stitch up your wounds, give you a little bit of some IV fluid and that sort of stuff. We're able to patch up and, make you feel a bit better. But there are some things that we may be limited to. For example, if somebody is having a full-on heart attack, we would not have the resources to deal with that or certain illnesses in an urgent care center. So the difference then becomes the level of acuity that we provide. Some things in the emergency room, if you think of urgent care and emergency rooms, you think of it as 2 points on a spectrum.
Right.
The urgent care center would be the lower end. And as you get into a bit more severe issues, then the emergency room is where you would want to be. And that's not to say that you shouldn't come directly to the emergency room if you have a certain level of concern. Absolutely, we're 24/7. We'd love to have you. It's just that the difference there is how deep we'd go into certain things, or what is it, your end goal is what it is that we do. That be one of the largest differences.
Yeah, I mean, I think the way we've talked about it is, the emergency room is definitively the place for life-threatening.
Yes.
Right. So I imagine a certain level of car accident, gunshot wounds.
Absolutely.
Like you said, the heart attack that's in the moment, stroke. I think those all kind of fall in the obvious lines of the emergency room. And I think sometimes that decision is predicated on location, right?
Yes.
So if I live in the East, I'm not necessarily driving to Blake Road to go to the urgent care center, even if I think what I have is not necessarily the emergency room, but it's beyond going to a regular physician, or it's after regular physician hours. Okay. So I think this is probably one of the more critical questions for our audience to get an answer to, because, and I think you've touched on this a little bit already, but can you share some tips for effectively communicating with whether it's the emergency room staff, the EMSs, and the ambulance space, if it's an ambulance visit that leads into the emergency room, in order to ensure the best care for yourself or a loved one?
Yeah, I think one of the best things that you can do, and it may seem counterintuitive because this could possibly be a real emergency, but you want to plan ahead.
Okay.
And what that means is, I know I'm going to the emergency room. I know what's bothering me. I need to be able the doctor to be able to answer this question. I am very concerned about this problem. I need him to be able to answer that for me. The other thing would be sometimes you may not be able, and we forget things all of the time. We rely on heuristics. You may not be able to remember all of the medications that you're on. That's fine. Bring the big bag. Help us to help you. The big bag with all of the medications that you have, bring it. You may not be able to remember what it was that your doctor said to you a few months ago at an appointment. That's fine. Bring the paper that he gave you when he discharged you. It helps us to piece together different types or different bits of information. So Plan your visit to the emergency room. You know you're going to go. I know I need to carry these things because I need them to be able to answer certain questions for me. The other thing would be nice. I think, and that's one of every healthcare provider's biggest pet peeves is when you have somebody that uses the fact that they don't feel well as an excuse for them to be rude. So if you come in and you're swearing at the staff and you're really inflammatory, that it makes it hard. It's not that we won't, but it makes it really hard for us not to develop not really hard for us to have some compassion.
Yeah.
Because it never feels nice.
And it can interfere with communication.
It interferes.
Right. Because what you're trying to get at is real hard information, and being rude and inflammatory doesn't really allow even that person who's being rude to get their full thought process across.
Yes. There's also the concept of shared decision making. So medicine is moving away from that paternal benevolence, whereas you do whatever it is that the doctor says. We're trying to move. We're moving towards a shared decision making where it is. I do this all the time. I would say to a patient, you have choice A, choice B, choice C. This is what's going to happen after you take any one of these choices. Here's what I feel you should do. However, if you're open to doing another choice, which is perfectly reasonable, let's talk about it and let's discuss it.
Okay, that's a good one. Jumping off of that, and I guess being rude and profane is probably the top of this list, but are there any other common mistakes that patients make when seeking care in the emergency room or at an urgent care center that could potentially hinder their treatment?
Yeah. There are so many.
That sounds like a laundry list.
It's a big laundry list. But the one that is very detrimental, please don't do this, is if you hide information. I always tell the patients, I am not a judge. I'm a doctor. I'm not here to pass judgment. I am here to help. And so sometimes you have, let's say, for example, a guy would go out and he would have a promiscuous night of fun. And so he'd come to the hospital and he'd say, oh, doc, just felt this tingling in my finger. I want you guys to do some blood tests. It's okay, no problem. I'm going to look for what are things or that could be life-threatening to that figure, to that finger. I'm not going to, and we don't have this machine that tells us every test in the book. So you do that and you'd come back and you'd say, okay, so I checked the finger and I checked your blood work. It looks okay. And then he's going to give you this look and he says, everything is okay. Are
you sure?
Are you sure?
Right.
And I'm like, yes, everything that we look for is okay. But what I mean is that everything that we checked for,
based on your complaint.
Based on your complaint.
Right.
And when he's probably concerned about things like, oh, did I contract this illness? Did I get that illness? Did I do this and this and that? And so don't hide that information
like
from
Dr.
us.
House said, everybody lies.
Everybody lies. Please don't lie to us. We're not here to judge. Just let us know. And
yeah, because your thing is about giving them the best care and the right care.
Yep.
Okay. Any other mistakes?
Yeah, people believe that, and you'd hear them, hear patients say this all the time. They believe that emergency care providers are robots. We're not. We are just like you. We have biases. We have feelings. We have good days. We have bad days. And I'd hear persons. We do our best to keep this out of the work environment, but understand that we are still human. And what that means then is being nice goes a very, very, very long way. You know, being understanding, and that, listen, we're not intentionally forgetting you. So if you may have asked us for a glass of water and somebody else rolled through the door with a life-threatening emergency and we prioritize them instead of your glass of water, that wasn't us offering inferior service. It was us simply having a moment where we forgot.
Mm-hmm.
Remind us it was not personal. So that part where persons be nice, it goes a long way. And I've seen, and then your nurse, if you're a good nurse, she could be your savior
Mm-hmm.
in there. She is going to have that relationship with you, and then sometimes she said, "Doc, I know you said that this patient has this, that, and that. I have a feeling about this.
Mm-hmm.
I have a feeling about that. And I've been in there with the patient for a longer time, and he's concerned about this. He's concerned about that." And they're really able to sway where it is that things go. Not that we would offer any special treatments, but
Mhm.
they can really, really help in our clinical thinking and decision making.
Yeah. All right. You mentioned nursing. We've talked a little bit about wait times, things like that. What measures are in place to handle overcrowding in the emergency, and how does that impact patient care? Because obviously, through the COVID-19 experience in particular,
Yeah.
overcrowding was a question. And obviously, if you have a mass event,
Yeah.
then there's always the possibility of having an overcrowded emergency room, and even just generally. We are noticing we're in healthcare, so we can see the increase in the level of need for healthcare services. So there's even just a regular random Tuesday night,
Right.
the emergency room could be busy just
Right.
because you have a lot of people that are ill. So what measures are in place to handle overcrowding and to help make that overall experience better for patients?
Yep, I'll answer that in a few dimensions. In the pre-hospital dimension, so we have been working with our ETS crew, and we've been offering them high levels of treatment, high levels of training and learning. And so they start your care way before you actually arrive to the hospital. And that plays a part so that when you actually get to the hospital, your throughput and your time is actually shortened. They also can take you they've trained in their level of acuity to know, and back to those urgent centers that we talked about, which cases are actually able to be treated in an urgent care center as opposed to going to the emergency room. And so we can divert different cases. If somebody lives out west and they just stub their toe, there's no need for us to bring you all the way to Doctor's Hospital on Collins Avenue. We can take you to the one on Blake Road, where they are just as capable of treating certain illnesses. And that's pre-hospital. When actually in the emergency room, we are starting to have more emergency room specialists. That becomes important now because we're better able to make fast decisions and more accurate and more precise decisions, and that helps the patients too. There is a possibility that I can figure out a few more problems without the need for certain aids because of the training. So we're bringing more specialists into the emergency room. The laboratory has started to incorporate lots more different testing that we can do, so we wouldn't have to wait for certain things. We have a triage process that we've recently revisited, and I think we're going to revisit it again, but we're trying to speed that up so persons have a shorter wait time. The emergency room is a revolving door. So when you're in hospital, any number of things that we can do to shorten your stay or get you to the next step is what it is that we prioritize. Now, we have a team on of nurses and administrators 24/7, and what they do every single morning, they have what we call a round, and so they go through the case of every person in the hospital that's admitted, and they talk about your care, what it is that you're here for, which day of stay is it, what's your trajectory going to be, and how they can improve your care and actually get you out of the hospital, and so we can now free up more spaces. And so there's that. More than just in the emergency room, the speed happens outside of it, and so there's that continuity of care that happens in the system. And we're really building that big system now, so we have more options and things that we can do instead of just holding you in the emergency room to make a decision. We
Mhm.
having more facilities.
Yeah.
It's
Sounds like there's a lot that's being done in that space in order to ensure that people are having the best possible experience through from start to finish.
yeah.
All right. So lastly, I want to ask you, just being forward thinking, looking into what the future of the emergency room looks like. What advancements or changes do you foresee in the future of emergency medicine that may improve either the patient experience, patient outcomes, as they visit the emergency room?
Yep. I think this is going to boil down to it'll boil down to concierge medicine or really personalized experience. For example, if John Smith comes to the emergency room, we would have already, before Mr. Smith got to the hospital, we would have already built a doctor's hospital profile or uh, uh, what's the word that I like? Well, a profile. Yeah, a
Mhm.
profile for him that he would be able to have an interaction with it. He would be able to upload into it his information, the medicine that he's taking, the primary care physician. He would have already seen any number of our primary care physicians before he got to the hospital. So
Right.
when he does have an emergency, we're able to really cater to exactly who you are.
Mhm.
I know already. I don't have to ask you a bunch of questions about what are your allergies, what are your medical illnesses. It's in that system. We've
Mhm.
already had that. I know when your last visit is. I know you've already gotten in touch with your primary care physician. So I know exactly what this visit is going to be like for you. And we would work. I see the care of the emergency room extending beyond the emergency room,
Mhm.
whereas we're able to offer a certain level of care in the comfort of your home. And that's really, really, really far thinking, but I think we're going to get there. Whereas we can come to you instead of you coming to
Mhm.
coming to us. That's way off.
Right. What about telemedicine? Do you think there's a space for telemedicine in emergency care?
100%. You have to. I wouldn't say that it's across the board. There's certain. So emergency medicine for me is a whole lot more, and it goes back to that Fingerspitzenfeld, that fingertip feel. It's a whole lot more than what it is that you say or what I can see on a camera. I need to pick up your. I need to pick up, and this is not weird, but there's certain smells.
Mhm.
Certain conditions, certain diseases have certain smells.
Right.
There's certain sights, sounds. It's the way that you're speaking to me. So, as an emergency medicine specialist, I try to use all 5 of my senses,
Mhm.
and then the 6th sense, which is common sense, to come to that final decision. So there are some things that we would be able to pick up in telehealth. If you say, "Oh, doc, yeah, I had this, I had that, I'm sore throat. Look at my throat." Yeah, sure,
Mhm.
something like that. But
Yeah, even
just
if it's just an initiation of the
yeah,
process, right?
yeah,
Because I guess I imagine it'd be similar to if the patient calls their primary care physician, and that information is relayed to you along with, like you said, especially if it's all within the same system,
yes,
then you have access to all of these
yep,
records as well. So even if you don't get a call from the physician, this person exists in our system already. You have that information, and all of that kind of adds details to the overall picture.
absolutely.
All right, awesome. This has been a very good conversation. Thank you, Dr. Seymour, for joining us, taking time out of your busy schedule.
Anytime.
Don't say anytime, because then we
Yeah,
could call you every time.
actually, not anytime.
But yeah, very, very good conversation. I hope that this helps to. I think for us, a part of it was to help demystify the whole process of the emergency room for
Right.
our listeners. So, as always, we encourage you to like, comment, subscribe, and share the podcast with your family and friends. And we'll be back here next week on the Doctors Hospital Podcast.
All right.
Are you ready to transform your relationship with nutrition? Doctors Hospital's clinical nutrition services are your first step towards a healthier lifestyle. Let us shift your knowledge of what and how to eat for a vibrant, energized you. Visit us today and discover a new world of delicious, nutritious choices. Doctors Hospital's clinical nutrition, where every bite brings you closer to wellness. Ask your doctor for a referral today or call 302-4600 extension food for more information.